Hello, I'm Todd Didier, Communications Director at the Primary Care Collaborative. Every month, the PCC recognizes outstanding leaders across the country who are working to strengthen primary care. This month, we're thrilled to recognize Dr. Lauren Hughes, who serves as co-chair of the NASM Standing Committee on Primary Care and the State Policy Director of the Farley Health Policy Center at the University of Colorado Anschutz Medical Campus. Previously, Lauren also served as Deputy Secretary for Health Innovation in the Pennsylvania Department of Health and has been a Robert Wood Johnson Foundation Clinical Scholar and a Robert Graham Center Scholar. Lauren, welcome.
Thank you so much, Todd. Happy to be here.
So why don't we go ahead, dive right in. You have a long background of being a champion of primary care. Could you tell us a little bit of how you became a primary care champion, why you're so passionate about strengthening high quality whole person primary care?
Absolutely. Truth be told, I knew by the age of 4 that I wanted to go into medicine. And if I'm honest, I would say by the time I graduated high school, I had a really good sense that family medicine was going to be my specialty, or at the very least, I wanted to pursue primary care. And I attribute this to Dr. J.R. Paulson. He was my family doctor from the time I was born until I was 18 and left for college. And he just retired last summer, no, a year and a half ago, as my parents' PCP, which is incredible. And so he was sort of my North Star. I thought growing up, I wanted to be a full scope rural Iowa family physician, be the excellent clinician that he was, to be a change agent in my community, like I witnessed him doing, and also to be a leader in the community beyond healthcare. So quite simply, I am passionate about high quality primary care because I have a very personal experience. I have seen it work and work really well. And a key ingredient to that was the opportunity to develop those longitudinal relationships between Dr. Paulson and my immediate family. And now from a professional sense in the work that I do, it is my belief that if someone is facing chronic illness or chronic stress, those two things can hold people back from being able to pursue educational and economic opportunities. And so I like to think in my own small way, if I'm working on policies to advance high quality primary care, it provides an opportunity for, for patients and families to be able to get and stay healthy and then pursue those opportunities if they so choose.
I think it's incredibly important that we recognize that health really is a core part of people's experience, and the whole health, people's full experience with their health and their health care and managing any conditions they might have really impacts not only their lives, but the lives of everyone around them. So one thing I did want to ask about,
Sure.
in your background, you have a lot of work that's focused on bolstering quality of care and access to care in rural areas. And we have seen that the primary care shortage, which we're all aware of, it's particularly acute in those rural areas. Based on your work and your background, if there were a single policy or industry-wide change you could implement to bolster primary care in rural settings, what would it be?
But when I think about our incredible clinicians that primary care clinicians that are living and working in rural and frontier communities, I think there is this anxiety sometimes, or of the unknown. What is going to walk through that door next? How urgent will it be? How emergent will the situation be that my patient is facing? And so sometimes that sense of being out there by yourself, being alone, and knowing that you don't have an extensive team to rely upon. You have to be able to manage everything that kind of walks through your door. And so that can be really unsettling or terrifying sometimes, I think, for some of our rural and frontier clinicians. And so a policy change that I would love to see would be to, and some of this already exists in part, but to make a much more robust 24/7 on-demand support system for our rural and frontier clinicians. And this may be sort of quicker access e-consults, a dedicated phone line, video support services, what have you, so that for that case or for that issue or that injury that walks through the door that you don't see every day, you're not alone. And I would love to see that be more universally accessible, synchronous, 24/7 on demand to support those clinicians working in these very valuable communities.
You previously served as a president of the American Medical Student Association. Every year, we're seeing fewer and fewer clinicians opt into primary care specialties.
Mhm.
So, what part of what you just discussed do you think plays a role in some of that attrition? And B, what can we do to address these shortages? Is it a matter of attracting more students and trainees, stemming the tide of those leaving practice? What steps do we need to make sure people feel comfortable in a primary care setting, and B, really bolster that workforce?
In response to what I was just saying around sort of an on-demand synchronous support sort of service for our rural and frontier clinicians, I think it speaks to underlying infrastructure that high quality primary care and our interprofessional primary care teams need in order to be successful. So access to resources, the IT support, training for these teams to know how to adapt to care delivery changes that they want to make, being able to pay for those broader team members like social workers, community health workers, peer support specialists that are really useful for improving health in communities. And so all those things are examples of what I think of infrastructure that ideally needs to be financed in a way that really supports robust, high quality primary care. And when our trainees are rotating in primary care settings and they're quick to observe challenges, quick to observe stress, quick to observe dysfunction if it exists. And I think a lot of those can be related to the underlying infrastructure that may or may not exist to support those primary care teams. And so that relates to what I was saying about sort of a 24/7, consult service for our rural clinicians that I think will be important for trainees going into primary care to realize, no, I'll be supported. I'll have access to the resources that I need in a timely way to deliver high quality primary care. I think another challenge for interest of trainees going into primary care is the widening gap in future earnings potential between specialists and primary care physicians, particularly in the face of rising and massive educational debt, depending on where it is that you have chosen to train. And our trainees are also quick to observe that difference as well. And payment discrepancies are one of many factors, I believe, that's contributing to the primary care access crisis, and in many ways to a physician's personal sense of worth and value in the broader healthcare delivery system. Because I believe that right sizing or kind of rebalancing, addressing those payment discrepancies in terms of future salaries, future earning potential, may make the field much more attractive as a sustainable career, in addition to financing the infrastructure elements needed to deliver robust primary care.
Yeah, no, I think that the primary care community would agree that there has been a sore underinvestment over the past few decades, and that has left us without the infrastructure and support that we need to really provide to primary care teams to do their role.
No, I agree. It's been chronic and compounded.
Absolutely. Yeah, I think
And we're witnessing the impacts of that lack of foresight, that lack of investment in primary care infrastructure now, and that's intimately tied to really severe access challenges to get into primary care or to establish primary care. So these pieces are all connected. They are absolutely all connected.
So you laid out a lot of excellent recommendations and ideas of policy solutions that can help address the access issue, the workforce issue, which really are one and the same in a lot of ways, and then also underinvestment. Are there other major policy initiatives that you think policymakers, either at the federal or state level, need to be paying attention to in order to make sure that we can really build the foundation of strong primary care that our nation deserves?
Absolutely. So, as you can imagine, as someone who loves policy and is a primary care clinician, I have a pretty robust list, but there is another one that sort of is at the top of that list, and that is focusing on primary care spend. I think moving forward, a really critical element of any of our delivery reform efforts in the primary care space, that accurately tracking primary care spend at the state and federal levels relative to other medical expenditures will be a really important part of this. Some colleagues of mine conducted a study last year and released a technical brief through AHRQ, the Agency for Healthcare Research and Quality. And that technical brief identified 67, I did not misspeak, 67 different definitions currently in play across the country of how to measure primary care spend. When you have 67 definitions of primary care spend, it does not set you up for easy comparisons, if that's even possible to do at all. And so I would strongly encourage our leaders at the state level and in Washington to develop and use a consistent definition of primary care, and also a consistent methodology for calculating primary care spend. What is going to be included, what isn't going to be included, so that we can make more accurate comparisons across states in different settings. If states want to additionally add other aspects of primary care services that they want to include in their definition, by all means, go ahead and do that, in addition to running calculations on sort of a universal, agreed upon definition and methodology that does allow us to compare and contrast different levels of primary care spend with some modicum of reliability in doing so.
Yes, and I think we also have run into a situation where some states even aren't measuring spend at all.
Oh,
And
correct.
then
Yes.
it's impossible to know what to fix if we aren't measuring where the shortfalls are.
Correct. Yeah, data is a critical element, certainly, to be able to transform primary care moving forward. So absolutely essential to have that information.
I do have one last question. It's a little bit more fun. We've been, in the nitty-gritty, we've been talking about the details a bit here, but kind of taking a little bit broader lens. And let's say I give you a magic wand, you can wave it and you can just change one thing about the healthcare system, as big or as small as you want, but it just changes overnight. If there's one thing you could change, what would it be?
I love these magic wand types of questions. And so I might add a little bit more than just one thing here, but it's all with the same premise. And so if I had a magic wand, I would completely disentangle primary care as well as behavioral health and oral health. Also very, very important for whole health, those two disciplines. But I would disentangle primary care, behavioral health, and oral health entirely from the notion of health insurance and publicly finance primary care, behavioral health, oral health, and public health, making these services universally available for everyone. And from a primary care perspective, this approach would make primary care a common good and truly at the foundation of our healthcare system as it's purported to be.
Fantastic. Well, thank you so much again for joining us, and thank you for all your hard work to strengthen primary care and advocate for policies that will lead to a healthier, happier nation.
Well, thank you. I appreciate the opportunity.